All right, thank you everyone for attending our clinical specialty workshop, and thank you to Dr. Soriano's, Andrews, and Dalton for coming out, sharing what they have. This one, as you can tell, is going to be based on crit care. Just to go through a quick little agenda right here for ACCP in general. We're going to have our first membership drive on the 21st, which is next week during lunchtime. If you're interested in the ACCP Student Travel Award, it's due on the 21st as well, same day. So if you're looking to try to save some money, that's something you should try to apply for. We have our first virtual GBM on the 22nd, also at lunchtime. Our P1 liaison applications will also go live during that time. So if you're interested in your P1, please show up to our GBM, find out what we have to offer, see what we can give you, see what you can get out of it, and ask us any questions. We also have a journal club with Dr. Wensler on September 24th in the morning, bright and early. But I promise you it'll be pretty helpful, pretty informative if you come out. So if you have time, please come out. The ACCP annual meeting interest form is also due on the 28th. If you're interested in coming with us to the annual meeting, there are discount rates that we will discuss on the GBM. So just if you have questions about what the annual meeting is, if you go, what's happening, just come and we'll let you know. And lastly, from what we have planned, we have a social networking with faculty. It's something we do every year. This year it's going to be virtual though, unfortunately, but you can come out, chat with the faculty. Usually it's for students who are interested in just who wants to get to know faculty or who are looking for research positions. If you're looking for research, it's a great chance to just talk, see who you vibe with, and see if you have any interest in anything. It's on October 7th and it's going to be at 6:30. All right, so let's continue with the workshop. I'm going to go over a brief introduction of the three pharmacists here. Dr. Vincent Soriano is one of our guests. He's currently a clinical pharmacist in the MICU at Cook County Stroger Hospital, close to UIC. He got his PharmD from UIC, and he did his PGY1 at UIC as well, but he went to do a PGY2 in critical care at Rush, which is also in the vicinity. Dr. Lauren Andrews, however, does not come from UIC. She's currently the first critical care infectious disease pharmacotherapy fellow at UIC. I'm gonna have questions about that. She had her PharmD degree from the University of Tennessee Health Science Center College of Pharmacy. She got her PGY1 in pharmacy practice at the University of Kansas Health System, and she got her PGY2 in crit care at UIC. Dr. Katie Dalton is our last guest. She's currently a PGY2 resident at UIC, but she's done all her training and schooling here. She's had her PharmD from UIC as well as her PGY1 from UIC as well. All right, before we get to our first questions, which I have on the screen, is there anything any of the guests wanted to say about yourself or your interests or anything like that?
I think the only thing that I would say is that, everything you guys have learned about pharmacy thus far can still be expanded. So I was never expecting to be in a position like this, but just kind of think of all the opportunities that pharmacy has to offer and all the networking that you can do while you're still in school. And we'll kind of expand upon this as we go through the questions, but just something to kind of think about now really early is that you're not just a clinical pharmacist in the hospital. You're not just, a pharmacist in the community. You can be so much more than that. So just something to think about.
I'll save my advice for later, but I will vouch for the travel awards because as a P2 and P3, I was the recipient of the Crit Care PRN travel awards and I presented research at the annual meeting. So it's definitely doable to get those travel awards and they do have a lot of money allocated out for that. So definitely apply for those.
Okay, thank you so much. All right, so our first questions, you guys can decide whoever wants to answer first. But basically the first question is, which rotations during your last year of school were most influential in your decision to basically pursue residency or a fellowship? And a second part to that is what ultimately led to you deciding to your current practice area?
You guys want to go up the chain there? Katie, you want to start?
Sure. Okay, so my P4 year, I already knew that I wanted to do a residency, and I already knew that I was interested in critical care. So during pharmacy, or a year before pharmacy school, I worked at Rush full time, and then I worked there all throughout pharmacy school. So I was exposed to clinical pharmacy before I even started pharmacy school. So I kind of set myself up all throughout school to pursue a residency and critical care, because I was just so fascinated by like the fast-paced environment just from the beginning. So for my rotations, I tried to do a rotation with Vince, but then he changed jobs, so my whole schedule got shifted around. But I was able to do a ED rotation at Masonic, which is a level 1 trauma center. So that was really interesting, even though the pharmacists there kind of focus on med recs as their like primary job responsibility in the ED, but they did respond to all the traumas when they came in. So I thought that was very interesting. And then Vince had just moved over to Stroger. So my third module, I was able to take MICU with him. So that was one of the best rotations, and I will rave about that until my grave. He was a great preceptor and great mentor. So that's kind of how I set up mine. I knew I was interested in residency and critical care, so I tried to get rotations in that. But you're not necessarily going to need rotations in your interest area in order to pursue a residency. So you can still make a good impression on your preceptor and learn a lot in your rotations, your clinical rotations, in order to get a residency. Lauren?
And I would definitely agree with Katie. You don't have to have, a critical care background. This was something that I was very passionate about from a personal standpoint coming out of high school. I didn't really know that pharmacists existed in the ICU until that point. So while I was in pharmacy school, I got a job at our level 1 trauma center in Memphis. It's called the Med, now Regional 1. And just trying to get more affiliated with how I felt about the critical care environment. It can really weigh on people, and it can be really difficult at times. And that was something that I needed to know that I could survive, really, so that I could, help out my patients and their families. And that's when patient advocacy became really important for me. I think this particular field is one where the pharmacist can really have a role in that. Versus the others, you're not having as much family contact. I feel like I get more family contact than I do patient contact sometimes, just because they're typically intubated, or there's some other reason why they can't speak with me. But just kind of with that job, I worked there for 3 years. And then during my 4th year of school at UT, I tried to, knowing that I wanted to be in crit care, tried to be in different types of ICU environments and ED environments, because as a new clinician coming out of school, I knew that there was a possibility with all the new pharmacy schools that jobs were going to be difficult. And so trying to determine, was I going to be going for a critical care residency or an emergency department residency? Because I feel like both of those are fairly compatible. And I chose critical care because I felt like doing that I could do both. And so I actually did a trauma ICU rotation at the hospital that I worked at, and then a nutrition rotation where I was still working in the trauma ICU with those patients, just kind of getting to learn more about them. And then I also did both a trauma and a community emergency department rotation. I think something that everybody worries about is that you're not going to be able to get rotations in the same field multiple times. And I think a way to get around that is to voice what you want from this rotation to your preceptors, because there were rotations where I said, I'm really ICU oriented. I'd really like to work with the ICU patients, on your service. Is that possible? And we were able to make that happen. For example, I did a rotation at St. Jude that was supposed to be more BMT, onc related, and I was really able to work more with their ICU patients and be exposed to medications that I wouldn't have otherwise. They weren't things that we really talked about in school. So, having that ability and talking to my preceptor and opening those lines of communication really helped me to kind of decide, there are so many facets of critical care that I could go into versus that one little bubble that I think a lot of people fall into when they just go to the MICU or they just go to neuro or they just go to cardio. So there's something to think about. And then for my job currently, I did not know that this was happening. So I was applying for jobs coming out of PGY2, with COVID, it's really difficult. Everything was very virtual. And I had networked and created relationships with the people that I work with, and I was approached by one of them, my current director, Eric Winsler, and asked if I would like to be a fellow for the program, and he was willing to make it a dual program so that I could do both critical care and infectious disease. So again, connections are really important, and the relationships that you build are really important. So always having a positive attitude, always looking, being ambitious and trying to put your best foot forward is going to be really important, because that first impression means everything. And if people believe in you, they're going to work for you. So just something to kind of keep in the back of your mind as you're going through rotations and trying to navigate this virtual world that we live in now. Vince?
Yeah, for me, I actually was really interested from the get-go for my P3 year. Mike Johnson, who was the MICU pharmacist before Scott, he was kind of one of my mentors like early in my career, and he was the one that really sparked my interest in critical care. Kind of like what Lauren and Katie were alluding to, I actually didn't get an ICU rotation until after I matched on my PGY1. So while I had my eye on critical care, honestly, I try to make the best of my clinical rotations. And honestly, my medicine rotation at UIC just kind of showed me how you can practice really at the top of your license as a clinical pharmacist, whether it's through your service or the amount of research and teaching that UIC clinical pharmacists have. I knew I wanted something like that in my career ultimately. So again, I didn't really have my rotation until after I matched, but I did finally have my neuro IC rotation with Eljim Tesoro, and it was phenomenal. He's still kind of one of my mentors now. And that kind of really solidified my choice in going into critical care. So that's kind of like a pretty traditional, I would say, path towards me going into my career right now. So again, not necessarily an alternative way getting to my career, but just a few kind of mentors kind of leading me towards what I was already interested in as a student.
All right, thank you. Next question. So it's separated to two based on where you're at. So Doctors Andrews and Soriano, what did you gain from doing your PGY1 and PGY2 residencies at two different institutions? And Dr. Dalton, what have you gained from doing it at the same institution? So basically the differences between your trainings.
I would say the biggest gain that I had out of being in really three different places for my training is perspective. Every institution is going to do something different, and I think being able to think with different groups is really important, because it helps you to learn how to create your own decisions and ideas. It's kind of part of the reason why I went down the track that I did, because I realized that out of all three places that I had worked and been exposed to, I really didn't get, a firm research training background. Residencies are built, for you to do a longitudinal project and, to be exposed, but not as in depth. And so really learning how other institutions utilize their electronic health record, how they, do like even their medication reconciliations, how do they counsel patients, how do they work with the teams. Every place is going to be different, and every region is going to be a little bit different too, and how people respond to pharmacy, how they utilize pharmacy. And so just kind of being aware that you might be in a situation where someone is not accustomed to having a pharmacist on their service. They may be more resistant to hearing what you have to say. And just getting that practice, I think, is really valuable. You get it a little bit during your rotations, but it's really different when you spend an entire year plus, trying to earn the trust and respect of physicians that are working around you. So for me, I think the biggest thing was definitely perspective.
Yeah, for me, I'll talk a little bit about the specifics going from UIC to Rush. So UIC is extremely, extremely great at teaching you how to approach patients from a clinical standpoint, especially working as a bedside clinician, which is one thing that they really do a good job focusing on. But I think my second year at Rush really complemented my first year training, because Rush is a little bit more similar to how most positions will be when you get your real clinical pharmacist job. Just to kind of understand that UIC is kind of like a pharmacy fantasy land. Like, no one has the resources like UIC other than other colleges of pharmacies, right? So if you kind of look at the clinical pharmacist to bed ratio at UIC, it's insane. Like you're not going to see that at other institutions. So what I kind of learned from Rush is kind of navigating in scenarios where pharmacy is not as strong relative to the other departments, navigating the politics kind of, and how to kind of conduct yourself with committees, and how to figure out who you need to know and get to know to get projects done, and how to become more influential in scenarios where maybe you're trying something new that a clinical pharmacist hasn't done yet. So that's been really instrumental for me here, which is a little bit of a middle ground with UIC and Rush, I would say. But yeah, to answer your question, long story short, one thing is kind of the different environment and the politics and kind of how to just navigate your way through the work that you want to do, quite different from UIC and Rush.
All right, so I stayed at UIC for both years of training. I think there's definitely pros and cons to like staying or going. So July is usually reserved for an orientation month for residents. So staying on as a PGY2, I was able to kind of get like an extra MICU rotation. So my first rotation was 7.5 weeks in the MICU rather than just a 4-week rotation starting in August. So I thought that was really cool. And then at UIC, when you stay on as a PGY2, you get to train the new residents on call. So I had 7 overnight shifts in July to train the new PGY1s, which was a lot of fun because they're kind of learning the system and how to be a pharmacist and just what to do overnight. It was a big slumber party every night. Also, you get to know the medical residents really well. So I worked with a lot of these same people last year as a PGY1, and now I'm working with them again. So they kind of trust me a lot more, and I just have a bigger role on the team, I feel like, because I already have that rapport with them. And it's fun, like overnight, when you get to respond to codes and just see your medical resident friends in that sense. Also, a benefit of UIC is that we are allowed to do away rotation. So even though we don't have like a trauma ICU or a cardiothoracic surgery ICU here at UIC, hopefully pending all the COVID restrictions, that I'll get to do these rotations still. So I won't be missing out on those experiences just because we don't have them at UIC. So I think overall there are some cons in the sense that you're learning from the same people and you're not expanding your network. But overall, I think the benefits kind of outweigh the cons in this sense.
That's good to hear. Thank you. Next question. What do you think gave you the biggest leg up to get to the position you are in today?
Are we still going up the chain? Katie, do you want to go first? Do you want me to just go ahead and go?
Either way, you can go if you want to.
I would have to say that since jobs are really fluid, you're not going to be in a job forever. So getting to a certain position doesn't mean that that's the position you're going to retire in. So understanding that and trying to take advantage of every opportunity that you get, I think gives you a huge leg up because it gives you the opportunity to, envision what other positions could be like. And that was kind of what I had going into this one. Not to mention that being in other places, I really learned what I did and did not want out of the people that I worked with. And so for me, being able to identify like good personality traits in my colleagues and the people that were training me and the people that I was training, what was that environment like? What were, people expecting from each other was really important. And so kind of having that, I feel like gave me a really huge leg up on being in this particular position because I realized that there are certain traits I needed from the people that I was going to be working with. And so when I identified those with, Eric and Scott, then I was able to say, I think this is something that would work for me. It's not the traditional path that I was tending to have. But looking back and realizing that there were a lot of people that I trained under that had done fellowships and, had that little extra, I don't know, edge, I guess. Not in a sense that maybe they were more competitive or something, but in the sense that they were better teachers. They could dissect literature and, actually tell me what it meant versus kind of telling me the surface material. And so that was kind of something else that I was really looking forward. And so just realizing that, I think, was a huge leg up for this. But Katie?
I would say if I had to pick one thing that was like the biggest influence on getting me to where I am today, was probably my experiences working at Rush, because I had a lot of opportunities to network with the pharmacists there and just seek out mentors in critical care that I was interested in. And with that came a lot of research opportunities. So as a P2, I started doing research with one of the pharmacists there, and then he just kind of kept feeding me projects after that. So it was just really helpful to have people that you look up to, that you're working with. And then as an intern, we wouldn't work as much, so I still would see them every once in a while. And even now at mid-year and stuff, I run into my old colleagues from Rush, and it's always a good time to see them. But I think just having that exposure early on kind of helped push me into the direction of seeking out all the opportunities. And I think in your guys' curriculum, something that we didn't have in the old curriculum is your IPPEs, going out on site earlier on. You get exposure to a lot of different areas of pharmacy. So I think you guys need to take advantage of that. And then I guess I would just recommend, if you can, to get an inpatient pharmacy job, because you will learn a lot about how a pharmacy operates in the inpatient setting. And I think that's very helpful for when you start a residency.
Yeah, for me, simply, I think just having really strong references. With my P4 rotation, PGY1 rotation, PGY2 rotations, I've pretty much kind of had contact with a lot of, prominent pharmacists, clinical pharmacists in the Chicagoland area. So when the question is asking about how I got here as the MICU pharmacist, well, to be honest, my managers told me that they reached out to all these other people, and they kind of got a sense of who I was as a person and as a pharmacist. So really important as a P4 for you guys as you get into your rotations to continue have really strong performance on rotations and keeping good ties with your preceptors, because it will definitely help you kind of get to the next step of your career.
Thank you again. Next question is, what does your work days or weeks typically look like at your positions now?
I can start. So as a resident, I'm constantly busy, 24/7. But right now I'm on the neuro ICU rotation. So my days, typically we will round with the neurosurgery residents at about 6:30 in the morning, which is very, very early. And then we round with a neurointensivist attending around 8 to 9. So they kind of follow some different patients than the neurosurgery team. So it is a little bit confusing of what team is covering what patient. But you go to rounds, make your interventions, talk about all the patients that your service is covering. UIC has something really great for the residents at 12:30 every day called Noon Report. So at Noon Report, we talk about the cases that happen on call, and just kind of put yourself in the shoes of what would I have done if I was in this position getting this call, and you just kind of go through the whole case and talk about it. So I try to attend Noon Report as much as possible. And then in the afternoon, I'll usually run the list with my preceptor, just go over all my recommendations and what the plans are for all the patients, and then kind of follow up on anything that you need to follow up on from the morning. And then the evenings are usually spent reading, doing projects, working on research. There's always things that need to be done, so constantly busy.
I have to say that is not something that I miss. So as a fellow, as a resident, I really enjoyed rotating. I really enjoyed being on rounds. I liked having relationships with the physicians on a day-to-day basis. That is something that I lack currently, just because when you enter a fellowship, your first priority is to get some projects off the ground so that you have something to work on. And then later on, you go back into the clinical arena and you get to, discuss things that you learned maybe while you were doing research for different grant proposals, or something that you did in the lab, and you can kind of talk about that within your institution with the people that you're now on service with, which is really cool. But I don't miss getting up super early. I think one of the best things about my fellowship is that it's really flexible, and I'm not stuck on a specific schedule. As long as I get my 40 hours a weekend, it doesn't really matter. Results are really what is important. And so, being able to say, oh, I have to do this at this time, or I have to do something like this and be on a panel at this time, it's not difficult for me to do that, which is really cool. So I would say, from the day-to-day, I typically come in, I check my emails like a normal desk job, and then I, start looking into my projects. So for the past 2 months now, I've been writing various grant proposals to various drug manufacturers in order to try to persuade them to give us money to study different characteristics of their drug. So one that I did recently was looking at brivaracetam and lacosamide in CRRT. They're two anti-epileptic drugs that are not as commonly used, just because they're older agents that people are more comfortable with. And so just providing that company with a little bit more data, I think, can bring a little bit, just more familiarity to the rest of us that are trying to use these medications, especially in the ICU. They're typically used as oral forms, but can be used as IV as well. And so that's something that they are interested in. Trying to determine if different clinical trials will be effective. So we're doing a proposal about terlipressin. So it's something that you guys learn in school when you're treating patients with cirrhosis and hepatorenal syndrome, but we don't have it approved here in the US. So it's not something that on a day-to-day basis I would get to see. And so trying to persuade that company to say, hey, we think it's, important for us to evaluate this particular patient population or something like that. And then other benefits of being in this job are, learning more about statistics, something that we kind of glaze over in school because nobody really understands them. And then, just trying to be more persuasive as a clinician overall. I mean, I spend all of my time trying to convince someone to give me hundreds of thousands of dollars to do experiments. And I think that is a skill that I'm going to be able to take to the clinical side of my job, when I'm making interventions, making recommendations to the team, trying to do things on committees. So yeah, it's just a lot of persuasion.
Yeah, for me, I guess after residency, it doesn't look that different after hearing how Katie described her day. Of course, maybe a couple notches less intense than back in PGY 1 year and PGY 2 year. So pretty similar. I would say my job is maybe 75% direct patient care, especially with COVID. Sometimes rounding till 1 o'clock is not unreasonable. I have a P4 and a PGY1 as well on rotation with me right now, so quite busy with teaching afterwards. Somehow go to committee meetings and eat lunch for like 10 seconds in between meetings. Try to do some clinical research with some of these residents. So pretty much kind of your 3 pillars that, research, teaching, and clinical pharmacy work at the bedside. Similar to a resident. So it doesn't end at residency.
All right, thank you. A little scared, thank you. What is your role in emergencies and COS, and how hands-on is your position as a crit care pharmacist?
You guys want me to start again? Okay. So at UIC, we have 24/7 code coverage for the pharmacists. So we are a part of the code team. So we respond to all number 1 emergencies, rapid responses, strokes. That's kind of what encompasses the code team. For number 1 emergencies, most hospitals call it code blue, but here we call it a number 1 emergency. The pharmacist will be in charge of all the medications at the crash cart. So we're in charge of like bedside clinical decision making, recommending the medications and kind of following the algorithms. A lot of the physicians will try to go outside the algorithm. So you're kind of the voice of reason over there, like, no, we don't need this sodium bicarbonate. So we respond 24/7. We have our on-call program, so the residents respond overnight. During the day, typically a PGY1 is covering the code pager, and then at the beginning of the year, a PGY2 will serve as backup. So about every third week, I'm in charge of the code pager as backup. So I have to go and respond and kind of observe the PGY1s and see if they're competent enough, and then I will sign off on them, and then they can carry it alone, even though at 5 p.m. it's a magical time and they're allowed to be on call by themselves. But it's nice because that's like another teaching opportunity that we get to have with the PGY1s, and it's like a near peer teaching opportunity. So I like that, but it's very hands-on at UIC, and they look to us to have recommendations. And after we get the patient back to life, we'll make drips at the bedside usually, or just kind of facilitate getting all the medications that the nurses might need. And I've even had to push medications before, which pharmacists are not supposed to do in Illinois, but sometimes you got to get the patient your medications.
So in my fellowship role, you can see that I'm in an office, so I'm not in the hospital currently. So I'm a little farther removed from being part of, the code process, but just kind of reiterating things that Katie said, it's a very hands-on experience here, but coming from other hospitals, it can be a different dynamic. Pharmacists are utilized, again, in different ways at different places. So I know we also include strokes in our emergencies and codes. So, other institutions sometimes don't utilize pharmacy at all in those situations. My last hospital, we had so many strokes come through that it wasn't feasible to have a pharmacist respond to all of them. We actually had a stroke code team that was made up of nurses and physicians that would kind of carry around their TPA and, respond to all the strokes and then evaluate after CT and things like that. So, I think for the most part, pharmacy has made a huge impact in being hands-on in these types of situations. And like Katie said, it's a great opportunity for you to kind of prove your worth in these situations. Not that you're trying to showboat your abilities, but trying to communicate with your physicians. And so the most important part when you are responding to codes is being able to communicate. I think a lot of us go into that situation because it's scary. There's a lot going on. There's a lot of people in the room. People are yelling. It's kind of a blur. But when you are supposed to be the medication expert and you are making recommendations on what to do next and keeping time, then it's important for you to be able to speak up and say something. Just your presence there is not the same as you actually verbally responding to a situation. And I think that really helps the physicians. It puts a lot of people at ease. So just kind of making yourself as useful as possible is another way to be hands-on.
Yeah, for for Cook County, we don't have enough pharmacy residents to provide 24-hour emergency response with pharmacy presence. So it'll be relegated to when I'm here on service. But in terms of codes, pretty much everything short of maybe intubating and starting a line, like I've done chest compressions, I've done the pulse check, I've recorded, I've mixed meds, pushed medications. And honestly, one thing to keep in mind when you guys get ACLS trained, technically if you're ACLS trained, you can run a code. So kind of don't be too scared to just be the, epi person. Really think about kind of the reversible causes, other ways that you could help out. Because what I kind of tell my trainees is like, you want to try to put yourself out there as much as you can to try to help. Because sometimes they might not think that you can offer anything more than giving epi every 3 minutes. So yeah, that's pretty much most of my involvement. Of course, with strokes and other emergencies, I come through as necessary. They usually page me.
All right. Next question. Looking back at your schooling and everything else, is there anything you would do differently if you could do it over again? And what advice would you give to current pharmacy students interested in critical care?
All right. So looking back, I don't know that I would necessarily do anything differently, but I guess just some advice that I would have for you is try to learn things to learn them and not just learn it for the exam and like pump and dump it. I think that's easier said than done. But once you get on rotations, it's much easier to apply your knowledge to patient care when you're not just memorizing things and you're actually learning them to understand them. And then, as I was alluding to before, I just think it's important to be involved, whether it's in an organization or in research. I think there's a lot of opportunities for you guys to get research. Like you should reach out to faculty if you're interested in a certain area because they're always looking for help with data collection and just help to carry out their research because they're very busy. And then I also think it's important to find good mentors and just ask them about their experiences and kind of what they've gone through. And because they've gone through the same thing not too long ago, they were in your shoes. So I think just finding good mentors, getting involved, and then just learning things to understand is my advice for you guys.
Yeah, I think mine is almost the same as Katie's. I know for myself, I was always looking to the next step. I was always like ready for the next thing. Like I'm in didactic classes now. I want to be on rotation. After rotations, I want to be graduated. I want to be in a residency, blah, blah, blah. You know, you're always looking forward to the next thing, but just live in the moment. You know, take the time to appreciate your classes. I know things are really weird right now. It's really virtual. It's hard to connect with people. You know, you feel probably kind of isolated sitting behind your computer screen and trying to make all these connections that we're telling you about. But, you know, take the extra minute to, as you're sitting in your class, absorb it and don't think about the next thing that's coming up. You know, and if you're struggling with something, reach out. I think that's another way to network. You know, if you've never asked, how are you going to know, right? So, you know, there are no stupid questions. And if you're willing to reach out and ask somebody and show that you are being vulnerable and that you know, really want to learn from somebody, it's really likely that you're going to build a connection with them and they might be a mentor to you in the future. And that kind of alludes to Katie's other point is mentors. You know, identifying someone that you aspire to be like. It doesn't have to be 100%, but somebody that you really believe has good character, that, you know, does good by their patients, that wants to help other people in the medical profession, whether it's physicians, nurses, you know, just someone that you feel like you can go to when you have questions, because there are going to be questions that there's no way for you to know the answer to. And so, especially as you're, you know, going through your career, what is a good move for me? Where do you see me fitting in? And getting that outside perspective can be really helpful.
Yeah, I think Katie and Lauren had really great points that I would also echo. For students in critical care, Dr. Schlemmer is still there, right? I would definitely keep those receptor lectures. It comes back all the time in critical care. It's one of the few disciplines where kind of all those things kind of come back. I think also pharmacokinetics. I probably asked Josiah to calculate KE and clearance like 100 times. So those are very valuable lectures. And honestly, like I remember as a student, I'll just kind of get through the exam. But as Katie said, these things will continue to be with you. And the mentors is a huge thing. Completely agree. I always strive to kind of, you know, be like my mentors. Scott and Elgin have been really influential to me. And I wouldn't be like the kind of clinical pharmacist that I am without them.
Thank you. All right. This one might be more of an example question, but where have you felt that you've been able to make the most impact during your career? And are there any patients who stand out particularly to you that you made that you made a difference for, or that you felt like you made a difference for?
All right, I'll go. Well, my career is very young, so I don't know that I've been able to have a chance to make a huge impact yet. But there is one patient that sticks in my mind when you guys ask this question. So I had a pregnant patient come in like a month and a half ago to the MICU, and she was transferred in from an outside hospital. And at first they had a positive COVID test for her. So she was admitted to our COVID side. And at that time, the outcomes in our COVID ICU were terrible. Like, all the patients were coming in, they were about 40 years old. They had no past medical history, but they were obese, and a lot of them were dying. So she came in, she was transferred in, and she was on paralytics, and she was on a bunch of sedatives. And it was like almost 5 p.m., which is when our pharmacy on call resident starts. So that's usually when we'll leave the unit. But this patient had just came in, and they were asking me all about her medications and the safety of using them in pregnancy. And I was terrified, to be honest. But so the patient, she ended up being paralyzed for about 4 days. We had to get a separate medication pump for her because we wanted to dose the paralytics on her ideal body weight and not her actual body weight, because it would have given her a lot more of the medication. So she was about 13 weeks pregnant, and one of the intensivists was saying that, I mean, at that point, you got to save the mom in order to save the baby. So a couple of days into her stay, we were discussing terminating the baby because they thought that the mom would have better outcomes if we did that. And so that was just kind of a decision that we were floating around for a while. And then she ended up having 2 negative COVID tests. So we transferred her to the other side of the ICU. And her husband would come in every day to see her. And it was just very touching. But so anyway, the sedatives really scared me because I just didn't know. I'd never taken care of a pregnant patient before, let alone a pregnant patient that was sedated and paralyzed. So I think that was just like a big moment of on your feet. You have to think quickly. And like, I think I reached out to Lauren that night because I was like, help, like, I don't have a preceptor. I don't know what to do. So I just kind of did the best I could. And at that point, you need to care more about the mom. So we weren't as concerned with what medications we were using that early on. But the patient ended up waking up, and she was transferred out of the ICU, and we did not terminate the baby, and the baby is still doing well. So I thought that was a nice success story around all the negatives and all the deaths that we had those surrounding weeks.
So similar to Katie, very short career thus far. I'm only in my 3rd year post-graduation. But I think something that has been really impactful that I've been able to be involved in is interprofessional education. I think kind of taking the opportunity to teach people outside of pharmacy is really, really helpful. It proves pharmacists, their value on the team as well as just within the institution overall, and it kind of opens a lot of other doors for us, including FTEs to get new jobs and things like that. And it just makes you a really valuable resource. Like, you truly become an asset when you are not just looking at your own profession, but you are looking at other professions. That all of our goal is to have optimal patient care, right? We're always trying to look for the best outcomes for our patients. And so just kind of having that mindset, I think, is really impactful, and it helps other people to envision you when they're thinking up a medication plan, or they're having a problem. They're like, oh, well, I can reach out to the pharmacist. She just taught me about paralytics and sedation, or vasopressors, or or COVID-19 therapies. There are things that we are very valuable for, and we're not just the books on the shelf. So I think that makes a huge impact. And that's something that you can do really early on, as a student, as a first-year resident, and as you continue through your career and continue to build on that. Thinking about patients that stand out to me that I know I made a difference in, they're kind of groups of people, and I think it has to do with being compassionate and having empathy for others. Typically our overdose patients and our sexual assault victims are the people that I feel like I make the most impact on. A lot of these people I met either while I was working in the ED on rotation or I was on a call, but being able to take the time to listen to someone is its own form of medicine. And so, with my overdose patients, I've had multiple different things. I've had Benadryl overdoses. I've had, can't think of the word, olanzapine overdoses, and we have heroin overdoses all the time. And I think just being present and letting them tell you their story. You know, you're not just getting the past medical history, you're not just getting, you know, the history of present illness, you're trying to piece together exactly what happened. And I think when you are receptive to what they're saying and you're non-judgmental, that you are able to get more of the story. You know, people really opened up to people that they feel comfortable with, right? So, and that's something that has kind of gone along with my sexual assault victims as well. They are traumatized. They just want someone who remotely understands what's going on. Sometimes they don't want to talk to anybody at all. And just being understanding of that, I think, is really impactful. And it's a way to remember that your patients are people. You know, I think over time, it's, especially in critical care, it gets really difficult for you to kind of keep up with all the patients that you have and, you know, all of these different events that occur in people's lives. You know, some of them can weigh pretty heavy on you, but not changing your perspective and putting them as just a number in the chart or a number on your list of things to do today. You know, I think the ICU is a very dehumanizing place. You know, our patients are not capable of taking care of themselves. They're fully reliant on the nurses and physicians to make good decisions for them. And so being a pharmacist and advocating for them and, you know, trying to remind people that there are other things in these people's lives that make an impact is really important. So, you know, like I said, I don't think it's just one patient that I've had, but there are little small things that you can do along the way that make an impact, even if they're the tiniest thing in the world. It can make a huge difference for your patient.
Yeah, I'd say as you kind of continue to practice and you get, you know, a few years under your belt, you'll definitely accumulate, you know, numerous very interesting, very impactful cases that Lauren and Katie were alluding to. I think the next thing too for me now that I found a lot more, I guess, gratification for my career moves is the impacting the hospital-wide care. So a lot of times what you want to start looking at is maybe changing how the practice can be done, especially if you're coming from a different institution with a different perspective, you can help an institution do something a little bit better. So for example, protocols or guidelines for very difficult things whether it be interpleural, you know, TPA and Dornase alpha guidance for the hospital, or, you know, massive PE protocol and how to deal with the paralytics and anticoagulation, and our recent transition to AUC monitoring. You know, you really are the focal point as a clinical pharmacist to educate both the physician, nursing, and your other pharmacist colleagues on kind of the best way to continue progressing the practice at your institution. I think that's been quite gratifying to be able to make an impact on a larger scale. Although, of course, those case-by-case bases always stick with me, and I could talk about cases for hours, honestly. But yeah, making an impact on a larger scale has been a really great.
Thank you for all your different perspectives. And the last part here, we save some time to have an audience Q&A. So if anyone in the audience, either turn on your mic, or if you want to type your question, that's okay too. Someone will read it out. Yeah.
Remote, or is everything still in person for you guys?
For me, I work in an office, so I'm pretty far removed from everyone, and we're fairly socially different distance. So I've been at work every day, and when I was on PGY2 rotations, I was still expected to be there every day on site. A little different for my students, just because we wanted to protect them, and they were all virtual. So I spent a lot of time on the phone in an office in the hospital. But I think for most of us, our job is not one that could be done from afar, especially since we typically are responding to code situations, and the teams are really reliant on us for rounding. It's just with the patient loads that we have, it's too difficult to be virtual. But I'm sure other institutions have figured it out somehow, but I think UIC likes to keep it close knit.
Yeah, at the beginning of COVID, I was on the transplant rotation and our students were virtual then, but last month I was in the MICU and our students were on site with us. So it's really just preceptor dependent at this point. But I think it's definitely challenging to do a rotation virtually because you want to be hands-on at the bedside learning those skills. But something we did at UIC is we implemented the fact that like pharmacists were not going in COVID patient rooms. So I have been in like 1 to 2 COVID patient rooms. And for when we respond to codes, the crash cart is outside of the room actually, which is a big change because before you were at the patient's bedside right in the room, which kind of made the communication aspect difficult, but we're making it work. And I think things are getting better and the census is decreasing.
Yeah, no change for me really. Everything's been in person. Apart from learners, except I guess Josiah was here during the height of it, so maybe not too different. So everything's been pretty much inpatient. Of course, my AmCare colleagues are working a little bit more remotely, but the clinics are opening up.
Let's see, Mark in the chat was asking about the switch from the PICU to an adult ICU. He said was the, oh wait, no, I'm not muted, okay. He said was the transition addition of patients overwhelming and how do you think it affected your day-to-day? So I think maybe Lauren could speak better on this because she was in all the crit care rotations during this where I was still rotating in different areas as a PGY1.
Yeah, so different from Katie's PGY2 experience, I had some electives planned and then I was moved to the MICU. So I actually spent about the last 3 months of my residency hanging out in the MICU and covering all of those patients. So it was a decent surplus. We had a full ICU on the 6th floor, and then we also had at least like 5 to 7, sometimes 10 patients that were down in our PICU. And when we transitioned that over, it was a little bit difficult. We were trying to determine how many pharmacists did we need. We actually pulled some of the neuro ICU pharmacists to help cover the MICU, in addition to me being there. Because right now, the only MICU pharmacist we have is Scott. So, for him to cover 30 patients is a lot. And so we ended up kind of splitting things up. I think something else that became kind of difficult is determining where the team was. And so I think, in the beginning, because we had formed good relationships and it was towards the end of my residency, I had a couple of their cell phone numbers, I was able to reach out to them, but I think that was part of the difficulty. I think for the most part, pharmacy operations did a good job of filling our Omnicell with things that we needed. We were able to communicate with central pharmacy to say, oh, actually we need this down here. It wasn't here. But I think the nurses did a good job of the transition. Patients were obviously pretty unaware. But I think for the most part, it went really smoothly. Just trying to deal with your additional census was kind of more of it. But you also were able to target different disease states and talk about them on rotation. So that was also cool.
Okay, we have a question from Michelle Jerkovic. She's asked, if you can think of a rotation you took that was very different from your current role, did you like it or dislike it and why? Can you share some experiences or perspective?
I can answer this one. Actually, I took a lot of clinical rotations. I think the most different one was my community rotation. I'll be honest, I did not like it. Reason being is I think you kind of learn really to manage a store. And I think just the atmosphere of community pharmacy, it's very, very difficult to make very clinical interventions. And I think for me, I get a lot of my gratification being a pharmacist from making these really thoughtful clinical recommendations and interventions. So unfortunately, it was not for me.
Yeah, I would agree with that statement. I actually worked in community for 2 years before pharmacy school, so I'd already kind of gotten my dose of what this was all about. And I think the pressure that's put on pharmacists in that setting is too much for me. It's a different kind of pressure to be in an ICU on a day-to-day basis, but to have your job kind of be led by a corporate enterprise that doesn't necessarily have your needs at the forefront of their mind is difficult. And I just didn't feel like for the longevity of my career and my life that I could do that and commit to that. I still think that community pharmacists make a huge impact, and I think that they, provide education when, patients aren't able to get to the physician's office. With COVID, we were there, we were able to answer questions for people that, when the clinics were closed, and that was a huge benefit. But I think when you're thinking about a job, what dynamic are you going to feel is healthy for you? And that one in particular just wasn't healthy for me. But there were plenty of other rotations that I had that were different, that had nothing to do with what I wanted to do. When I was in school, like I mentioned, I did BMT, ONC in a children's hospital. I did an internal med at a children's hospital. I do not want to take care of children. They're like little aliens that are not for me. They're very cute, but it doesn't really fit in with my stress level. I feel like peds is a lot more stressful, not quite what I'm looking for. But, I think all of those experiences give you, again, another piece to your perspective. So, if you guys are going through the rotation selection process and you're like, oh, I really want this, and you end up with something else and you're like, there's no way that that could be good, take the time to talk to your preceptor and tell them, like, this is what I hope to get out of this rotation. It's not what I expected, but, I want to make the best of it. And they will help you get there, and they will make that experience what you want out of it. So, just communicate with them and ask questions.
Yeah, I'll echo what Lauren and Vince both said. I was not cut out for community pharmacy. I had never stepped foot behind a community pharmacy counter until my P4 rotation. I knew my preceptor, which was helpful because he would always make fun of me and just give me a lot of work and make me do all the stuff that he didn't feel like doing. But I think, yeah, it is important to just make the best out of whatever situation you're in. Even if it's not your number one choice, there's still lots to be learned from your preceptor and your patients that you'll be taking care of during that rotation. So, and it's also important for your preceptors to tailor the rotation to you. So if you're interested in, say, community pharmacy, and we're here in the transplant ICU, then maybe we'll focus on you educating a lot of your patients, because you'll be doing the counseling when you're a community pharmacist. So just finding ways to incorporate something that you enjoy doing, even if it's not exactly what you want to do. I think there's another question for you, Lauren, in the chat.
Yeah, so one question from Michelle Lee. Lauren, is your fellowship 1 or 2 years, and what sort of quick care or ID questions are you researching?
Yeah, so this is a brand new program at UIC, and so I'm kind of the guinea pig. It will be for 2 years currently. The department head for the College of Pharmacy really wants to see this be successful. We initially kind of discussed, would this be a transitionary role just to kind of get the program up and running? Would it have the potential to be a 1-year situation? And I think ultimately we decided that based on the projects that we wanted to get into, we weren't going to be able to do that in a 1-year period. There's a lot to fellowship that I think gets kind of overlooked when we're thinking about, what school we're going to go to, what residency we're going to try to apply to. Fellowship is not the same. You're used to being in a clinical role, and now you are in a research role, and it's just a different environment and a different way of thinking about things. thinking of projects that we're working on. So our main ID project, which the contract just got approved and we're sending the IRB through currently, is for imipenem relebactam. So another gram-negative antibiotic. And so we're looking at the pharmacokinetics and the relationship in obesity patients and how effective is this medication in those particular ones. So when that one actually gets up and running, that one is technically a phase 3. Yeah, phase 3 clinical trial. So I'll actually be up on the unit. I'm going to be taking a phlebotomy course, so I'll be drawing the samples myself, and then I will take them to the lab, spin them down, and then take my samples and freeze them for analysis. We don't do any of our quantitative analysis in-house. We actually outsource that to Keystone Bioanalytical. So that's something I don't have to do, but just kind of having that extra experience I think is really cool. As I mentioned earlier, there's a couple of anti-epileptics we want to look at and how they operate in continuous renal replacement therapy, which has kind of become a passion of mine. As I kind of went through most of my rotations, most of my preceptors said, oh, we can extrapolate the data to this. And I think now that I've gotten into a position where I can actually research that and determine, how different CRT modalities affect how we clear drugs, I have a completely different answer to that. I think it is really individualized. I mentioned the terlipressin in hepatorenal syndrome. We're actually looking at data in minority patients. So the current trials that are out there and the big trials that are moving this towards FDA approval in the United States are based in majority Caucasian male populations. And so for our particular patient group, which is typically minority, low income, doesn't have a very high health literacy, typically are coming in a lot later in disease progression. This is something that we really wanted to look at to see how effective is this drug later on in the disease course. Other things, I worked on another CRT project last year looking at apixaban, trying to determine of the oral DOACs, does this one need to be renally adjusted for patients that are getting, this type of dialysis? And that is currently accepted for revision to a journal. So hopefully you guys will get to check that out soon. But a lot of different things. My fellowship is not based solely on ID or solely on critical care. It's a broad scope of other opportunities. And there are little things that I do on a day-to-day basis, like call the microlab to screen C. diff PCRs to see if they're appropriate. Katie knows all about this because I've called her a million times. Trying to be a good antimicrobial steward from afar. And again, I think it's how do you become a persuasive clinician? So, yeah.
Well, thank you. Thank you for everyone who asked questions, and thank you for our speakers for showing up and sharing their knowledge. If there's anything you guys like to close with, feel free. But otherwise, yeah, thank you so much, Dr. Soriano, Dr. Andrews, and Dr. Dalton.